Good evening. We are on the 103rd lecture of iFocus series. This is the 7th in the glaucoma modules. And we are continuing with the diagnostics with Dr. Arun Narayanaswamy from Singapore National Eye Center, speaking on anterior segment imaging, on which he has worked immensely. I would hand over to Vanita to introduce him, then Arun will start off with the lecture. Vanita?
Yeah, thank you very much. We have a very special guest here today from Singapore's SNEC, Singapore National Eye Center. He is very well known to the glaucoma circuit here, not only because he was very much part of Shankar Nethralaya for a while, and then also came back for a short stint in EyeCam Noida. But he's a senior consultant, long years of experience. He's published widely, especially in anterior segment imaging, as well as has been an invited faculty to many national, international conferences. Team CFS extends a very hearty welcome to him. We appreciate the time he's giving us. It is now, I think, 10:30 in Singapore, and is going to be much later when we finish. Please join us, Dr. Arun.
I hope the audio is clear. Thank you, Vanita. Thank you, chairpersons. Thank you, Santosh, for this invite. It's been long overdue, I think. So I guess I go ahead and start with this talk. So Santosh asked me to cover anti-segment imaging in glaucoma. I would say it's an overview because comprehensive is never ending. Okay, I guess I have to repeat some share screen stuff. Is that?
Yes, please.
Yeah, should I probably need to redo it? Is that?
Yes. That's
I'm not having a page down that, because no idea why that happens. Just a moment.
Then sometimes the tagging.
Okay. Maybe just the lag. Are you guys okay now?
Not seen yet, Arun.
Okay.
It got unshared. Yeah, that's right. Correct.
Oh, there is a problem with the move slide.
Click on it once and then it will probably start. Yeah. Now you can use up and down.
Okay, great. Right, so this talk will cover the imaging platforms, technological principles, the reading of an output, some clinical applications, the pros and cons of each of these technologies, some insights from research, and then we'll look at its comparison with the clinical standard. So angle evaluation, like as all of you know, is key to glaucoma diagnosis and management. The current reference standard is the Gonioscopy, and it involves the visualization of the angle structures, nearly a direct visualization and inference of the angle structures. However, there are some issues in terms of its subjectivity. It is grossly observer dependent, needs a significant amount of expertise. The lighting conditions influence one's inference, and there are many kinds of lenses, and the recording of findings are quite different. So as I said, a significant amount of training and expertise is required. This is where adjunctive cross-sectional imaging technologies have come into play. The first and foremost technology was the ultrasound biomicroscopy, followed by the anterior segment OCT platforms, which came in many variants, some of them being the spectral domain platform, followed by the web source OCT platform. I'll also talk briefly about the on-fast imaging, that is the Retcam. Now, taking on and going on with the ultrasound biomicroscope, now this was one of the most revolutionary technologies that altered angle imaging and anterior segment imaging. This instrumentation is based on a high-frequency ultrasound B-scan. Typically, the probe frequencies are 50 megahertz and 35 megahertz. that helps you image the eye somewhere between 5 millimeters to 7 millimeters scan depth. Most often, the scan is done in a supine position with a water bath or probably gel. And the current modifications of the scan allow you to achieve what was initially a quadrant scan to convert them into sulcus to sulcus scans. Just a short summary as to compare what is the difference between the B scan and the UBM. Just the basics are that the B scan probe is of a lower frequency, hence greater imaging depth but lower resolution, whereas the UBM is of higher frequency, hence lower imaging depth and higher resolution. So this is the image of the probe modifications, wherein you can conduct the UBM examination in a sitting posture, which is generally the more supine, more physiological posture to acquire an imaging. So like I said, this technology has been revolutionary and continues to be so because of the high resolution capture of the anterior segment, especially of the retroiridial ciliary body zonular complex. As of today, there's no other imaging technology that is able to still capture this kind of resolution of the zonules, the lens capsule, and the ciliary process behind the iris. This gave us a lot of insights into many aspects of glaucoma. Before I move on to that, I'd like to just give a brief overview so that you understand what these images mean and how these scans are done. The typical standard scan involves the axial capture with the probe facing the central cornea along the horizontal and the vertical meridians. This is what you end up seeing. Then you do the paraaxial across the limbus to get each quadrant, and you focus on each quadrant. The transverse scan is done parallel to the limbus, and this is the orientation of the ciliary process you do when you do the transverse scan. The overview of the printout, again, very important to orient yourself as to which eye you're looking at. All of this is available. Now you see on the top left corner, which is highlighted, this is the right eye. Then this is the scan 1 and 2 represent the horizontal and vertical central scans, and followed by which you have the indication of the clock hour of the scan in every picture, like this is the 6 o'clock hour scan. Then you have the red speck in the corner that suggests the nose, and thereby you know which clock hour you're exactly viewing. Going on to interpreting the landmark, this is the most important aspect, especially when you're dealing with evaluating an angle. Now, it is important to pick a landmark, and that landmark happened to be the scleral spur, typically a point of high reflectivity, and a point where there's an inflection of the concave cornea facing down to concave, or concave cornea moving up. So this particular point is important because it's a surrogate for your trabecular meshwork. Now, once we've identified this point, any iris contact to the angle wall is suggestive of angle closure. So that's how you make sense of this imaging technology as far as the angle evaluation goes. Now, UBM did a lot of changes to what we knew about glaucoma. It refined and strengthened our concepts, especially the imaging of the iris ciliary body complex gave us new insights into different pathologies and also helped modify approach to therapy. Now we know relative pupillary block has been described over many decades. We have to really give it to our predecessors to have actually described it so well without even having a look at what's going on behind the iris. The advent of the UBM confirmed these aspects and held our concepts and made them more concrete as far as relative pupillary block goes. You see an image of angle closure in the dark with the bowing of the iris. There is a stretching of the iris in light, and following iridotomy, there is opening up of the angle and flattening up of the iris curvature. In terms of pigment dispersion, again, there was a lot of information as to how the pigment is released. The conclusive evidence of iridozonular contact was established with the UBM, and subsequently some efforts were made to relieve the iridozonular contact during iridotomy, which was again demonstrated with the UBM. Plateau iris was received much more structure when we had a visual inspection of what is really going on behind the iris. Plateau iris had better definition criteria with the advent of UBM, like you see this image here, the closure of the angle, the absence of the iridociliary sulcus, and the anteriorly rotated ciliary process. All of these components together are definitive of a plateau iris. A lot of times, expert gonioscopy can give you this information, but then many a times it's hard to infer because angle can remain crowded for many reasons. This is a further evaluation of the eyes with plateau iris, where an iridotomy has very minimal effect as far as opening up of the anterior chamber angle goes. When you see a narrow angle on gonioscopy, and probably you notice an uneven contour of the iris, most often you probably think of iridociliary cysts. Now, sometimes you may find surprises, such as a tumor. Now, without this technology, it's hard to pick out unusual diagnoses such as these, and that's where the advantage of technology such as the UBM comes into play. Now, a lot of lens-induced glaucomas, the diagnosis is fairly straightforward, especially if you have a secondary angle closure due to subluxation. You see most of it can be inferred on the slit lamp by examination. But the additional information that you get from the UBM is the lack of zonules, the loss of zonules, and all this helps you plan surgery and probably do it in a better way with better outcome for the patients. So this is where the technology is useful in evaluating and managing the patients. Now again, you have a straightforward diagnosis of phacolytic glaucoma here, but then the additional information you gain from the UBM is whether the zonules are intact or not. Now this will help you plan surgery, discuss prognosis, and probably have a better visual outcome for the patient when the surgery is better planned. Aqueous misdirection syndrome got redefined with the advent of UBM. Just to explain the structures that you see, this is the cornea, this is the iris, and the flat anterior chamber, and the anteriorly rotated ciliary process. These are the components that you typically see when there is aqueous misdirection, or what is commonly referred as malignant glaucoma. What the UBM helped us learn more about aqueous misdirection is the presence of ciliary effusion in some of these cases. Now, Rich and colleagues worked on this a lot and finally came up with the suggestion that when we are able to demonstrate a supraciliary effusion in the presence of a presumed aqueous misdirection, the potential of it responding to medical therapy, that is less conservative, less aggressive measures such as medical therapy, probably a YAG hyalodotomy, and the outcome of it being better is seen in this group of eyes with the supraciliary effusion. Whereas on the other hand, you image and you see no supraciliary effusion, it's an indication that you need to aggressively manage them with a surgical approach. So these are the insights that the UBM gave us in terms of further learning about well-known entities. Unfortunately, hypotony also falls under the glaucoma surgeon's purview, and gonioscopy is quite challenging in a very soft eye. Thereby, a UBM or an anti-segment OCT is able to pick up the cleft for you and delineate it fairly well. What we learned along the way when we were imaging many of these eyes is that there's an unusual entity of uveal effusion seen in angle closure eyes. Now, this was demonstrated very well by Sakai and colleagues who evaluated almost about 501 subjects, wherein they noted that the uveal effusion was present in about 58% of the eyes with angle closure, and 23% of the fellow eyes with non-attack eyes also had this uveal effusion. Further, they demonstrated that the shallower anterior chamber depth in chronic angle closure eyes with effusion was noted, whereas when compared to eyes without effusion. Though we do not know the temporal sequence of this, we know that there's a novel mechanism associated with angle closure, and we continue to learn more about it. Now, when you look at an eye like this, you really are desperate for more information as to what your next step would be. That is where the UBM comes in handy. You're able to assess the anterior segment. You want to decide about what you want to do about your intraocular pressure and what your surgical steps are going to be before, in many ways, it helps you with accurate planning and to ensure better outcome for the patient. Along the way, a lot of quantitative parameters were developed that was applied in further research, and we talk more about it because most of these have been adapted into the anti-segment OCT platforms. So moving on to the next imaging platform, that is the anterior segment OCT. So there have been several generations of these OCT platforms, starting from the time domain to spectral domain, followed by the SWEP source. The essential change here is the scan speed, and higher scan speed meant higher resolution. A further advancement was what is meridional scans, that is the scans that you see here, did change into circumferential scans or on-fast scannings or a 360-degree scan with the ability of SWEP source technology. I heard that, okay, I would wait for the question. I hear there are some hot seaters who would like to answer some questions. I'll probably throw a question or two soon. So the time domain OCT platform was the first platform that we were able to access and image the anterior segment of the eye. So generally based on low coherence interferometry, uses a 1310 nanometer wavelength of light. The spatial resolution of this technology is about 10 to 20 microns. Now, the advantages of the AS-OCTs are the non-contact technique, rapid acquisition of the image with the patient in sitting posture. One disadvantage would be the inability to image the retroiridial structure, because essentially what you're using here to image the anterior segment of the eye is light, and light is blocked by the pigment epithelium, thus making the retroiridial structures less visible. So again, comparing the two technologies, the UBM is a contact technology, needs a significant amount of expertise, it's time consuming, fairly uncomfortable for the patient. Most of the examinations are done in the supine position. There is some amount of globe distortion that can lead to inaccurate findings because of the cup that I showed in the initial image that we use to hold the fluid. On the other hand, the anterior segment OCT is non-contact, the great ease of operation, rapid capture, very comfortable for the patient. And the only disadvantage, like I discussed, is the absence of the inability to pick up the retroiridial structures. So could I have the hot seaters tell me what the image on the left of the screen and the right of the screen is? Which technology is each one of them and why?
So on the left is UBM, because you can see the retroiridial.
Sorry, go ahead.
Louder, please.
Sir, on the left is UBM, because we can see some retroiridial structure.
You mean where my cursor is, where my pointer is? What image is that?
No, sir, that is AS-OCT.
Right.
Retroiridial structure is not seen.
Very good. And what do you see here?
The cornea, the iridocorneal contact is there.
Perfect. And here, a little less, so you'd probably call it uneven.
Yes, sir.
Okay, so this was a secondary angle closure with a sublux lens. So what do you think is happening here?
So this is a UBM of
Yeah, you're right.
left eye, because the nose is on the medial side here. So, and
what do you think?
Uneven, there is a iridocorneal contact.
Yeah.
Lens looks subluxated. Zonules are there on the lateral side.
There are a few zonules, maybe. Okay. But there is a space here, right?
Yes.
What do you think it could be?
It is also most probably a subluxated lens.
Correct. So possibly, right.
Lenses.
So there is zonular sparsity, yes, and there's probably vitreous that's pushing the iris and causing the iridocorneal contact. So you see how these technologies are complementary and probably give you a little more information. So when you're given out something to read, one ability is to differentiate whether the technology is the anterior segment OCT or the UBM, like you rightly pointed out. Look for these structures much better seen in these areas. And then, of course, for other clues as to why there is a difference between, here's typically you assume probably nothing else is wrong, but here you have greater information in the form of lack of zonules and possibly a vitreous prolapse pushing the iris forward. Okay, so let's go back to the basics again. How to look at an AS-OCT printout? Essentially, look at the eye, which is marked for you. Then you have the second information as to which is the nasal and temporal quadrant. I hope you can see them. And then you have the scan line, which is running across along the horizontal meridian. The bottom of the arrow almost always lies to the left side of the screen. So this is a vertical scan. It's hard to obtain a vertical scan without manipulating the lids, especially in this part of the world. And you can again look at the scan line running from bottom to the top, and the inferior angle image fairly well here. The other clues to know that it's the inferior angle is to look at the lid artifacts that is caused because of the lid blocking the scan line. So this is the basics you need to look for, the right, left, nasal, temporal, and you're able to identify what quadrant you're looking at. Again, the most important landmark to identify would be the scleral spur to make sense as to what you're going to do with this image. The scleral spur identification follows the same principles as the ultrasound biomicroscopy, typically again highly reflective and the change in curvature. Why do we need to know the scleral spur? It's a surrogate for the trabecular meshwork, which lies just anterior to the scleral spur. So the next point is what defines angle closure. What defines angle closure is any contact of the iris to the angle wall anterior to the scleral spur is suggestive of angle closure. So you see an eye with angle closure here and an eye with angle which is open because there's no iridotrabecular contact anterior to the scleral spur. Now the challenge is, what is the consistency of visualizing the scleral spur? This is where we look at a few images. You look at this image with angle closure, fairly well identified scleral spur. At the same time, the image here, it's hard to identify the scleral spur. So again, an open angle, the sclera tends to follow a continuous line, whereas inability to conclusively say that you can see the scleral spur. However, you go by visual clues and then decide whether the angle is open or not, and finally, again, go back to your basics, that is, do a gonioscopy to decide what next. So the group in Singapore really evaluated a large number of eyes to see how often we are able to identify the scleral spur conclusively, and on an average, it was noted in about 70% of the images, one was able to identify the scleral spur. So what does this mean? Essentially, you're not able to decide whether the angle is closed or not in almost about 45% of the eyes, because the specificity is about 55%, and 45% of the population, when you image them with the AS-OCT, can be false positive. So we still need gonioscopy to confirm angle closure on AS-OCT. So not really the most ideal tool to determine whether there's angle closure or not. So the problem of not being able to recognize the scleral spur as accurately, nearly 30% of the eyes, made people look at higher definition scans. So they moved on to the high definition of the spectral domain OCT to see if it could do better in terms of identifying the structures of the angle. Again, some of the common technologies are the Cirrus and the OptoView that is based on the spectral domain platform. Typically, they're designed for retinal imaging, but with adapters, they're used for anterior segment imaging. And this is the kind of resolution you can get with this technology. You're able to identify the termination of the descendants of the Schwabi's line. Scleral spur, not the best, but still can be seen. And you're able to see the trabecular meshwork. Now the point is whether this helped change as to how we can use it to determine whether the angle is closed or not. Further evaluation, we in our group from Singapore noted that almost in about 93% of the eyes, they were able to determine the Schwabi's line. And that means you move backwards and determine and decide whether the angle is open or closed based on your ability to identify the Schwabi's line. So this is the most common technology that is currently used to image the angle, typically designed, like I said, for retinal imaging, but sulcus to sulcus imaging is possible with adapters such as this, which is the anterior chamber module for the angle, and then you have a corneal module for a detailed corneal evaluation. Now, the drawback of the AS-OCT technologies was that it could image only a 10 to 20 micron sliver of the angle. It does not give you a global overview of the angle. So this is where they moved on to look at a further technology, which is called the swept source technology. Now, the advantage of this technology, if you were simultaneously watching the video, is that it's able to capture nearly 360 degrees of the angle in under 2 seconds. So essentially, that's how long it takes to capture the entire 360-degree angle. So what the technology is able to do is to capture nearly almost 128 cross-sections, and one is able to average all these cross-sections to determine whether the angle is open or closed based on some software. And then you also had this on-fast imaging, which would allow you a 360-degree view of the angle. So a semi-quantitative evaluation of the angle was possible with this technology, wherein you could determine, after recognizing the scleral spur and the endpoint, that is the contact of the iris with the angle wall, you could come up with a parameter called as the iridotrabecular contact index. So the red line you see here is the scleral spur, and in a closed angle, iridotrabecular index closer to 100, whereas in an open angle, the iridotrabecular index is lower. So this is an example of a closed angle, wherein the iridotrabecular index is 100%, that means 360-degree closure, and the example of an open angle where the iridotrabecular index is just 15%, and probably about, you can look at probably about 1 or less than one quadrant of angle closure. The imaging technology can be further used to look at other areas such as bleb evaluation, wherein you see a well-demonstrated stoma, the intrascleral pathway, and the bleb cavity. The image here is the one of an eye with an Ultrasound implant, and at about 30 days, you continue to see the stoma, the intrascleral pathway, and the Ultrasound implant. Very useful in evaluating problems caused by tube. Here you see a tube cornea contact. Sometimes it may be very difficult to evaluate in the presence of edema, and the AS-OCT can be a handy tool. Here you see an example of secondary angle closure caused by implantable contact lens. The implantable contact lens is seen here. This is the phakic lens. Now, very important to now, clinical diagnosis is fairly straightforward, but it's extremely important for you to document the problems from a medical legal point of view, because before you intervene, you have to ensure that all this is well documented so that you are not held responsible for further complications from a second surgery. With time and with the Zhongshan angle assessment program, a lot of quantitative parameters evolved, especially in the assessment of the iris in the form of iris area, iris curvature, and a lot of other iris parameters, as well as the angle measurement parameters such as the angle width and parameters such as IOD 500, the trabecular iris space area, and so on. Now, what the AS-OCT helped us with is the dynamic assessment of the interaction between the iris, the lens, and its relation to angle closure. This was the AS-OCT technology threw in a lot of insights as to how these interact, and what we knew about angle closure as a relative pupillary block is not just relative pupillary block anymore, and you'll know why now. So a lot of work has gone on with regards to angle closure. Multiple iris parameters such as the iris curvature, iris thickness, and iris area are associated with narrow angles. The study from Ong and group noted that a greater iris curvature, iris thickness, and iris area was significantly associated with the presence of narrow angles, even after adjusting for anterior chamber depth, axial length, age, gender, and pupil size. Further, parameters such as the iris volume changes with mydriasis, the dynamic assessment of it, and its relationship to angle closure has been evaluated and studied by a significant group of members in the scientific community. Other measurements such as anterior chamber width, which is essentially the width from scleral spur to the scleral spur. And this parameter has been noted to be associated with a small anterior chamber width has been noted to be associated with eyes with angle closure. And a further parameter was the lens vault, which is essentially the extent of the lens that is located anterior to the AC width line. And this again has been associated with angle closure. Eyes with angle closure have been noted to have a steeper lens vault compared to eyes with open angles, wherein the lens vault is smaller. So what it really opened our eyes to was that angle closure glaucoma is not a homogeneous disease. There's a relative importance of various factors involving the iris, lens, and a lot of dynamics involved, and each eye may have a different reason for an exaggerated angle closure. So the anatomical risk factors may be different in different individuals, and the therapy again may be different and may need to be individualized based on the risk factors. And we continue to learn more about these risk factors. I think this is a good time to take a step back now that we've reviewed a lot of expensive technologies, and to look at what does it really offer. Now, you look at the cost, this is what it is. And let us have a review, a critical look at what the technology offers versus the clinical standard. Now, the AS-OCT essentially gives you a black and white image of this sort, right? And you make your inferences from this. Whereas the Gonioscopy, a very simple tool, gives you something like this. Now, you have to tell me which one would want to take up as far as your practice goes, or which one gives you clinically useful information and to what extent. So the Gonioscopy is extremely useful in the form of your ability to do a dynamic assessment. Now, as you know, this is not possible with the imaging technologies. Now, with dynamic assessment, you understand pathology better, right? You see a narrow angle here on a compression with the 4-mirror gonioscope. You know the angle opens up, and you learn a lot more about this eye. You learn the extent of pigmentation. You look at the extent of synechia. So there are a lot of relevant things that is help you prognosticate the likely effect of your therapy. And that's how gonioscopy has been crucial in our practice and extremely an essential part of our practice, especially with regard to glaucoma management. Now, on an imaging tool, this is peripheral anterior synechia, right? So you don't know. What else would you want to know about a peripheral anterior synechia? Any of the hot seaters?
The extent of it, how many degrees?
Mm-hmm. So let me call this as I mean, probably not right to label it as, iridocorneal apposition. Then what would you say?
We want to know whether it is a positional angle closure or synechia.
Right. So that's what you want to know. And an imaging technology cannot tell you that. So that's the core information that is missing. The other things are whether this is primary or this is secondary. Now, I'll run through some examples as to how synechia, how gonioscopy gives you clues that are of immense value. Now, let us say in an eye like this, you run the AS-OCT. So when the AS-OCT runs through this part of the angle on the AS-OCT is open. But can anybody describe what you see on this part of the angle? Right. Right. So I would say this is a non-indented view of an angle. So there is simultaneous areas of open angle and synechial closure. So most likely this is likely to be a secondary closure, and you put the clinical things together. This is the case of eye syndrome, wherein typically without any indentation, you see areas of an open angle, some amount of synechia that are typical to eye syndrome, and of course the other clinical features. Now again, the style of synechia here, scallop, broad base, very typical of uveitis. On an imaging technology, this is just going to be the image that I showed you. Anybody comment about this pigmentation pattern here? Okay, this image. Shall we move here? You see the difference between the pigmentation pattern here and here.
Sample is a line.
Maybe, but this is, I would say this is the trabeculum. What is the feature?
Sir, continuous dense pigmentation in the first one, sir.
Right.
And in the second one, there is the pigmentation is not continuous. Sir.
Correct. So where do you see such things? Dense, velvety, continuous pigmentation typical of?
Sir, pigment dispersion syndrome, sir.
Right. And patchy?
Patchy it can occur in
many situations, yes.
uveitis also.
Right.
Pseudo-X.
Right. Great. So on an imaging, this is what you get. Whereas on a gonioscopy, you get diagnosis straight away. You're probably looking at pigment dispersion on your left and probably looking at pseudo-exfoliation on your right. So these are the crucial advantages of learning a very basic technique and to be proficient with it in managing glaucoma. So to summarize, what has imaging really added? It has added an objective component. It has helped us control some illumination-related influences. And of course, a very crucial part which we discuss is to visualize the iridociliary complex. Some of the limitations of this technology is that it's limited to a 10 to 20 micron cross-section, whereas with the gonioscopy, you're seeing the entire quadrant and nearly 360 degrees of the angle to make an inference. You're not able to indent. Some of the intricate visual information is missing, like I discussed, and there are some limitations to the angle assessment software and skills per definition. Do I have enough time to run through a case?
Yes, please do.
Okay. So again, to re-emphasize how we can use imaging when really necessary. This is an example of a 27-year-old Chinese male who presented to some of my colleagues with pain in the right eye, intermittent blurring of vision, and a headache for about 12 hours. So his refraction was known prior. He was a myope of -5 and -8. He had a history of right eye amblyopia and retinopathy of prematurity. Examination, his visual acuity was counting fingers. Intraocular pressure at presentation was 53 millimeters of mercury. Gonioscopy showed a closed iridocorneal angle. The left eye had a normal anterior segment with normal intraocular pressure and open angles. Fundus examination showed a Cup-Disc ratio of 0.4 and changes that's typical of ROP. So now the point was, what is unusual about this case? Anybody?
It's unilateral.
Right. Angle closure, and what is the refractive error?
It's -4, -8 point.
Yeah, would you expect it?
No.
Can, but very rarely can happen in drug-induced angle closures. Is that right?
Like topiramate.
Right. Okay. But so this is an atypical angle closure. Fellow eye is open, but topiramate has to be bilateral. Isn't that right? In general.
Yeah.
Right. So the lens was fairly stable, not sublux. We got some biometry information. The lens thickness was different. The right eye was thicker. Axial length was shorter in the right eye. So this is what the UBM showed. Could anybody describe? I mean, the significant clues there. The top is the right eye and the bottom is the left eye.
So steeper lens wall thickness in the upper image.
Mm-hmm. So very clearly a very spherical lens, and of course a very thick lens from this measurement. So the intraocular pressure did not respond to conservative management. This is the left eye, by the way, fairly normal, and it responded to a lens extraction eventually. So this is the montage image using the AS-OCT demonstrating the same thing. So this is where you use the imaging and its information. There was crucial information here that the imaging was able to tell what's going on. I mean, it's an atypical case, myope, and you were able to pick up this rare case of unilateral spirophakia causing angle closure in a young adult. So this is how you use imaging to your advantage to learn and to understand pathophysiology better. Very shortly about Retcam. Retcam is essentially designed for evaluation of and management of pediatric posterior segment diseases, but It has an adapter wherein we are able to image the angle using the 130-degree lens module. It does use a lot of light, but then there are some benefits of this kind of imaging. One is for documenting, because gonioscopy and goniophotography is quite challenging. More importantly, documenting this in pediatric glaucoma. Now, it's very difficult to teach and train people in pediatric glaucoma and to demonstrate what's going on in the angles because of the limited ability to examine them in the outpatient clinics. This is where a Retcam is useful to document these angles and also to capture optic disc photography in these particular children for follow-up. So this is where I feel the Retcam has a useful impact in our practice. So overall, to summarize, angle imaging is an extremely useful technology for objective documentation and patient education. It has added some crucial information to our understanding of angle closures, such as in Plateau iris, aqueous misdirection, and also the novel entity of supraciliary effusion. It has a significant clinical impact when used judiciously, and gonioscopy skills continue to be crucial and an integral part of glaucoma management. You continue to learn all your life when you do a gonioscopy regularly. So keep practicing gonioscopy, and that would be my take-home message for today. And thank you, everyone. And I guess I hand this over to the chairperson and moderator. Thank you.
Thank you so much. That was an enviable collection of imaging of the anterior segment.
Thank you. A lot of contribution from people you know, maybe.
That's correct. Yes. No, it's great teamwork, actually. Yeah. So I would invite Dr. Harsh and Dr. Pradeep to give us their thoughts, and then we haven't got any questions so far, but I have formulated a few
Right.
from the trainees' point of view, so we could go through them in a minute. Dr. Harsh?
Okay, thank you so much. I think we also learned so much. It was so
Thank you, sir.
really, and I want to thank Santosh for getting all the top people, because truly, I think it's a revelation for all of us also. And the beauty was that he kept it simple also, despite telling all the complicated things. He managed to
When they shook me up saying postgraduate training, so I said, okay.
But a lot of people forget that. So you have drilled the fact that gonioscopy has the upper hand. So
It definitely does, yeah.
Right, definitely, because that is one thing which their examiners will ask, because a lot of examiners will not even have seen this kind of a thing at all. So they would just ask, maybe theory question could very well be there, but let me tell you, Arun, what it has helped us in practice is that once you get an image like that, you can always convince the patient to get a peripheral anidotomy done. And the other important thing that all of you, the students, should remember that, yes, okay, you have done your gonioscopy, the patient is not convinced. I have got no symptoms. What do you want to do? You want to do a hole in my eye? Are you foolish? So, and then you show them this image, it really makes a difference. And the last case he shows was so good and typical, because though that was a little different, but in case we want that it is the lens vault which is causing the thing, and we want to remove the lens slightly earlier than when it is fully cataractous or something like that, again, this kind of a thing will help us tremendously. So thank you, Arun. That's all I can say.
Thank you, everyone.
Wonderfully. Pradeep, please.
Yeah. Thank you, Arun. Wonderful. And we usually we have been discussing about the AS-OCT for almost 15 years, and I learned a lot from you. It was fantastic lecture. Amazing.
Thank you, sir.
But for the PGs, all these technologies, they have their own role to play in the practice. Like the gonioscopy is most critical. And obviously, gonioscopy, there is no substitute of the gonioscopy. But the other technologies are the complementary technologies. And there are many situations where you have to use the UBM, where you have to use the AS-OCT, and where the Retcam might be very useful to you. If you want to visualize the red-to-iris structure, obviously the gonioscopy cannot do that. If you have a corneal scar, the gonioscopy cannot see the inside structure. So in these patients, this technology does help a lot. And if you want the objective technology, and if you don't want to touch the patient's eye, then I'm sure that Arun must be using the automated gonioscopy from Nikon. Is that right, Arun? Are you?
Oh, no. I just go with my Sysman 4 mirror for the last 25 years.
Okay, so that's a gold standard. The Sysman 4 mirror.
Though I have not had access to that. The Nikon, I think it is able to capture all 4 quadrants when you applanate the cornea or something like that. Yeah, that's the.
But that's wonderful, amazing. Yes, Vanita.
Yes, right. So I think that, the type of questions that our PGs tend to get is, a little bit more, for want of a better word, mundane, in the sense that they probably ask, what are your indications for doing a UBM? What clinical situations would you consider doing a UBM? So it'd be great if you could enumerate your indications.
So am I audible? Yeah. Okay. Fine. So typically, a UBM comes into play when you're dealing with a posterior pushing mechanism kind of a pathology. Many times you're not able to know that just by the first examination, but then when you know that you've done your regular exam, you've done the gonioscopy, you're not able to indent, there's something else going on in the retroiridial space, or a typical presentation like an aqueous misdirection probably is one place where I said that you should think of using information from the UBM to decide which way you want to go, how aggressive you want to be with regards to your management. In terms of plateau iris, I'd say you don't need to use an UBM. All you need to do is repeat a dynamic gonioscopy after your iridotomy, and you're able to clinch the diagnosis. So you don't really need to do a UBM with regards to that. With regard to bilateral angle closures, rare entities such as drug-induced angle closure, which we just discussed, again, there's a posterior mechanism involved. So it's crucial to pick that up because your many times gonioscopy is not good enough to tell you what next, and the presence of effusion, and of course, so many times you cannot pull this history out of the patient. So because there are drugs related to behavioral problems and so on, and they don't declare it, or you're not able to get it out. But when you clearly see a bilateral effusion, you need to dig into this information to decide what's going on. You may find a similar problem with VKH syndrome. You may have bilateral effusion with angle closure. So this is where in unique situations where something is perplexing, that's when you try to use information from the UBM.
Arun,
yeah.
You were my first teacher for teaching the Visante. And at that time, we used to discuss a lot about the iris thickness and the lens vault and so on and so forth. And you had the software and you did share with me for that. So what's your take? Because the angle closer glaucoma is also a continuum like open angle glaucoma. So where you can pick up that in very, very early stage where the iris thickness is more, the lens vault is very significant. What's your take on that?
So, the Zhongshan angle assessment program continues to give you all this information, but as of now, I don't think we've gone into clinical practice using these as benchmarks. You still go by your standard clinical evaluation and not by what information the AS-OCT gives you in the form of a lens vault or an iris thickness. So as of today, our practice has not changed because of the quantitative measurements that we get out of this software. I would still say that the guidelines that we continue to use in terms of the extent of the lens changes, the pros and cons of lens extraction for a particular patient versus an iridotomy, I guess we continue to follow our current guidelines, which I think is fairly standard. And as of today, very rarely have I made a decision of something like a lens extraction from the AS-OCT. it's almost always been a clinical discussion of pros and cons.
And Arun, you had shown a beautiful picture of the iris pigment and the iris getting away from that. But to the best of my knowledge, that debate is still going on. So would you, for PGs, would you say that a peripheral iridotomy is a must in pigmented dispersion syndrome, or would you still hold it?
Absolutely not. Yes, there was a small group of patients wherein people did demonstrate the presence of iridozonular contact, not iridolenticular contact. So they said it's justified when maybe you can discuss the option with the patient of doing an iridotomy, especially these patients tend to be young, you see. And if you need to release the iridozonular contact, some of the options you have are some pilocarpine, and then you have a lens extraction. Then all of them are very challenging options to offer this patient. So if the IOP is high and patient is not suitable for and not responding to medical therapy or not tolerating medical therapy, maybe it's an option that you discuss with the patient. But overall, the effectiveness of this has been very limited in terms of intraocular pressure control. But in a quiet eye, where the IOP is normal, even in the presence of active pigment dispersion, I would not offer a laser iridotomy in any of these patients. It's only in an active eye where the IOP is high and the patient is not tolerating medication, and as we know, we rarely use pilocarpine in young patients. Maybe you can consider discussing it with the patient, but then you have other options which are probably the pigmentary glaucoma responds better to, like the SLT. So the iridotomy is almost, I would say, it's probably redundant now for pigment dispersion.
Right. Just getting back to the indications, I wanted to highlight, you did make a point about, documentation for medical legal purposes. And a case comes to mind where a patient had visited 4 different ophthalmologists in the last sort of 2-3 months and was not being able to get his problem sorted, which was a very vague brow ache. And he too was a high myope. He was -6 something in both eyes. And lo and behold, he actually had angle closure, primary angle closure. To document that, I had to do a UBM to show it to him. I saw beautiful, formed posterior chamber, very rarely picked up, very, very rarely picked up. Post PI, of course, all that vanished. But then he was also a Plateau iris syndrome with a significant lens wall. So even that was contributing. So one question I wanted to ask you before we actually say goodnight to you, and thank you for your time, is, would you not do UBM post PI when the angles are still occludable? Because you're assuming that it's only Plateau iris syndrome which is contributing to it and not lens vault.
If you really, if there's no harm in doing it, of course, you learn more. In terms of to know the lens vault, I would say an AS-OCT is a better option because you need a nice central scan,
yes.
Right? To know the mechanism as such, it is still angle crowding.
Mm-hmm.
If it is a Plateau iris, you will be able to pick up with doing an indentation gonioscopy anyway. If it's due to other mechanisms, yes, an UBM can tell you a little more because it could be related to small irises all around the angle. It could be iris thickness. So no harm in learning more about to educate the patient or to plan your next step. So absolutely no harm in repeating an UBM and confirming
As Dr. Harsh pointed out, yes, we have to do that quite often just to educate the patients.
Yeah, I mean, the patient will probably so gratified when you show him on the next scan that your iridotomy is actually opened up the channel. So really no harm to
The point is, would you actually, if you're suspecting really suspecting a Plateau iris syndrome, would you still go ahead with an LPI, or would you think about iridoplasty, or would you or is this still standard treatment in Singapore?
Okay, so one thing I'd like to clarify is, I think the Plateau iris configuration and the syndrome.
Yes, no, we're not talking about.
So in terms of, you mean to say a quiescent Plateau iris, wherein the angle is not opened up, or you're talking about a clinical situation that the intraocular pressure is still raised following an iridotomy with the Plateau iris configuration?
No, the patient has just come to you and, probably has a UBM with him or her, and you can see that it's iridociliary sulcus is absent. There's anteriorly positioned ciliary processes. So, do we need to go through, what I'm trying to ask is, do we need to go through the process of eliminating what we think, relative pupillary block may still be present? That's the point.
Yeah, I mean, I still go by the old school of doing an iridotomy first.
Right.
For these angles which look, because the definition of a Plateau iris is following an iridotomy, the angle remains closed, and then you indent and decide whether.
Thank you. That is
so
exactly
I would still do an
what
iridotomy as my first step, and I think it
that you
continues
have to eliminate. Yes.
Correct. So there is no question of presuming that there can't be relative pupillary block.
Okay.
But Vanita, they are the one who does maximum number of iridoplasty in the world.
That will after
that may be after the PI.
After the PI, yes. So all our cases were after the PI.
Yeah. Okay. Right. Thank you so much. We really enjoyed this session.
Thank you, everyone.
With
so
you.
Nice to see you all. I hope all of you stay safe.
Right.
And we get over this soon.
Night. Yes.
Thank you, Santosh. Thank you, sir. Good night.
Right.
Good night, everyone. Bye-bye.
Right. Actually, the discussion did go on a little while, but we have some time. So we'll kick it off. Otherwise, we will never get going. So here we are, all the hot seaters. I hope you are awake and seated. Yes. So look at these discs first, okay? Every disc photograph I show you, I have a story behind it. The reason I document is because there is a story. So have a close look, and I would request Dr. Ajiba to comment about them. Are you there, Dr. Ajiba?
Yes, ma'am.
Yeah, okay.
On the right side, there is the.
So when you get to see now you look at it as though you are actually at an exam. Okay, this is like a practice for you. So what have you been presented with? These are color photographs.
It is a color photo, color fundus photo. Means color.
Well, not the entire fundus.
Yes, ma'am. This photo.
Yes. So color disc photographs of the right and left eye.
And the left eye.
Yes. Okay. Now tell me about the right eye. So what are the 5 points? This is what I try. This is what I want you guys to get into the habit of talking. First and foremost, look at the size. Especially when you have both discs together, you can make out a relative size. So what about the size?
There's a size asymmetry between the two eyes, ma'am. The cup of the right eye.
Yes, very good. Larger. I did not talk about the cup. Please don't jump to the cup. You guys always.
Size of optic disc of right eye is relatively larger than left.
The optic disc of the right eye is larger than the left. Very good. Okay. Then the second point is look at the neuroretinal rim. What would you like to comment about that?
There's nasal notching in the right eye.
nasal notching is not a word I would ever use. It's either superior or inferior. Remember, your nasal rim generally is the last to go. That is why even in the end stage, patients have small temporal island of vision. So nasal is not what you're looking for in glaucoma. What are you looking? Superior, inferior.
Inferior.
Okay, talk about the superior and inferior rims.
Ma'am, the neuroretinal rim is thinner in right eye compared to left eye, but still it feels it follows that IS&T rule.
Okay, you think it's following the IS&T rule. Who was that? I didn't see you. Veer. Was that Dr. Veer?
Yeah, ma'am.
Okay. Anyone else thinks it follows IS&T rule?
Ma'am, in the right eye,
One at a time.
Ma'am, superior appears more thinner than the inferior.
Who's that, please?
Ma'am,
Piyushi?
Piyushi.
Yeah,
Yes, ma'am.
yeah. Tell me again.
Ma'am, superior appears more thinner than the inferior, ma'am.
That's IS&T rule.
So you're
In
actually
the right eye.
it is following IS&T rule. Yeah. What about the left eye? What about the left eye?
There is
the
inferior
left eye is
notching, ma'am.
following the isn't rule.
Is following the isn't rule.
Isn't rule.
Piyushi said that, yeah? You said
No,
that?
ma'am, Sanjana.
Sanjana said, okay. Right. Now, okay. The next step is the RNFL. What do you think about the RNFL?
Appears healthy in both the eyes, ma'am.
So you think there is no RNFL loss in both the eyes?
Ma'am, in right eye there is inferior RNFL loss. Same in the left eye, ma'am.
Where inferior? Here?
Yes, ma'am.
Here?
Ma'am, inferior to that, this
picture.
Inferior to the disc, here.
Yes, ma'am.
Okay, that's what you feel. What about the left eye? Same.
Yes, ma'am.
Okay, then do you see any disc hemorrhage?
No disc hemorrhages.
No, ma'am.
No disc.
No hemorrhages, ma'am.
And peripapillary atrophy worth noting?
No, ma'am.
Yeah.
No,
Why am
ma'am.
I asking you these questions? Because this is how you need to see the disc. You talk about the size, you talk about the neuroretinal rim, doesn't matter if you get it wrong, okay? But your systematic way of approaching it will be appreciated. Then the RNFL, then whether there are any disc hemorrhages present, and then when there is any peripapillary atrophy. So I actually disagree with you guys. I don't think there isn't rule is maintained. How do you find out where the rim? By the bend of the vessel. Yeah, you trace it from the floor, and where the blood vessel bends, that's where your rim is. So when I am marking, I marked it out for you. I think the inferior rim is less than the superior rim.
Yeah.
Do you think that now?
Yes, ma'am.
Isn't rule? Isn't it? Okay.
It's not over.
So then, how do you know? Then how do you know if the rim is not giving you the clue of whether the disc may be glaucomatous or not, or has glaucomatous features or not? Then how do you know that the disc is normal or not?
By looking at the nerve fiber layer. RNFL.
Absolutely. So you just said nerve fiber layer is absolutely fine. There is no nerve fiber layer defect. Look at the red free also. Beautiful nerve fiber. So superior and inferior arcuate fibers, fantastically patterned, textured. And you always have a transition to a less brighter papillomacular bundle. Don't forget that also. So that may just tilt your decision, saying that, okay, maybe that is the pathology here. But no, you can still see pattern. You can still see texture. So that was for the right eye. This left eye is the same. Let me give you a history of this gentleman. 58-year-old, he came to me quite a while ago, maybe in 2012 or something. He came to me with a diagnosis of glaucoma for 12 years. So he was on postgraduate and analog for 12 years. When I examined his pressure, it was 14 in both eyes. His CCT was virtually average. His angles were open. And then when I examined his discs, both eyes, I found them to be, what would you call it now? is not obeyed here also. Look at the bend of the vessel. Don't look at the pallor. You guys make the mistake of just looking at the pallor. You have to look at the bend of the vessel. Again, inferior is less than superior, or at the most equal to superior. It's not more than superior. Okay, but look at the pattern. Beautiful RNFL pattern. Okay, so what is this?
Physiologically large cup.
Absolutely. Okay, so now what do? A patient has been told he will go blind if he does not put his drops. 12 years he has gone with the tag of being glaucoma. Not one documented pressure, not one documented visual field. So long ago, we did not have OCT anyway. So isn't rule not obeyed in both eyes, but they are still normal. So how do you prove? Obviously, do your usual tests. What do? You do your visual field test first. Okay, that on the right side first. Right side should always be on the right side of the where you're viewing it, not on the left side. Okay, and the left side also a little bit of total deviation, but no pattern deviation worth of note. I hope that Dr. GC made very clear. We have 3 non-edge points. Well, they should not be non-edge in 24-2. 3 contiguous points, but 1 has to be depressed less than 1%.
1.
So that is not significant at all. Okay, and what else do? You do a
Post-2NH.
yes.
OCT.
And do you see anything wrong with that? Beautiful. Look at
No.
it's 130s, your superior and inferior. So what do you have to do here now? You have to reverse the diagnosis of glaucoma. You almost fell at my feet. So why do we make these mistakes? Okay, the other point I wanted to make on the OCT is, what did we say clinically? Right was larger than the left. Yeah, so the OCT
Left is larger.
That also. No, this is the left, that's smaller.
Oh, okay,
Slightly smaller than the right. Okay, so these are the points that you need to pick up when so you may be just shown this and said, what is the visual field defect you're expecting? Okay, so it's your clinical conviction, which should say that these are, and you deduce, you say that I'm not seeing, any changes suggestive of glaucoma because of these points. So this is completely normal. Okay, was that helpful?
Yes, ma'am.
Yes, ma'am.
Yes.
So every day we have lectures. Hopefully I will bring up, one complete case so that you guys learn more and more and not make these kind of mistakes. Okay, this really is unpardonable. 12 years he went around. Okay, right? And that is pretty common, I'm telling you. 12 years was the longest I faced, but 5 years, 2 years, 6 months, 1 year is all the time. All right, so thank you guys. Thank you for being
Thank you, ma'am.
Such responsive hot seaters.
Thank you, ma'am.
We'll
Thank you, ma'am.
on Friday. Okay,
Thank you,
Friday.
ma'am.
Yeah. What was our talk on Friday?
Thank you, ma'am.
Yeah, you're welcome. Good night.
Glaucoma suspect.
Yes, that's correct. By Dr. Sagarika Patyal. Okay. Thank you, everyone. Bye-bye. Good night.
Thank you, ma'am. Good night, ma'am.
Thanks.